Welcome to the official podcast of the Ogden Surgical Medical Society. Since 1945, the Ogden Surgical Medical Society has been educating our medical community. In this podcast, we bring you the voices of medical experts in your community and from around the world. Please note that the opinions and ideas shared on this podcast are those of the speakers and not the opinions of the Ogden Surgical Medical Society or its board. While medical topics will be discussed, it should not be taken as strict medical advice, and individual clinical judgment is warranted in applying information to patient care. It is the responsibility of the listener to judge for themselves the applicability of the information discussed with regards to their medical practice.
Welcome everyone to the Ogden Surgical Medical Society podcast. Today we are just in such great appreciation for Dr. Kirsten Baca. She is visiting us again. Well, I guess she's not visiting us. She's here as the incoming president of the Ogden Surgical Medical Society, and so we all have kind of become familiar with you, Kirsten, but I do want to sort of read your bio. She's a board-certified anesthesiologist and pain medicine specialist, and she practices 100% pain medicine in Clinton, Utah, as a solo practitioner with a physician assistant and a team at Glacier Peak Pain Care. Now, this part is cool. Dr. Baca studied chemical engineering at Virginia Tech. We'll get into some of those chemicals today, I think, maybe. And then she finished with a bachelor's in biochemistry with a minor in chemistry. We don't have very many of these people over here in Utah, but she went on to earn her doctorate in medicine at Johns Hopkins University in Baltimore. So a little known university. And she completed her residency and pain fellowship in anesthesiology and pain medicine at Harvard's Massachusetts University, or Massachusetts General Hospital in Boston. She resides in Davis County and runs her outpatient clinic near Hill Air Force Base. As a pain physician, she sees all types of pain patients, probably some of yours. They're varying from acute to perioperative to chronic and cancer pain. She treats all ages, from older children to elderly adults. She has a special interest in ketamine, and as it is applied in the management of complex chronic pain conditions. She's here today to discuss that practice. So Dr. Baca, I'm really excited to talk with you. Welcome. Thank you.
Thank you, Dr. Moore. I am so glad to be here, and I'm really excited to share some of my knowledge on this very fascinating medication.
Yeah, well, ketamine for me, so I started my medical journey, most people know, as a pathologist. We don't really have a ton to do with ketamine. Sometimes, rarely though. I do have a side tangent. I did almost become an anesthesiologist, so I did have some ketamine experience there. But I think first off, before we start the discussion, what is ketamine?
Yeah.
What does it do? What is it?
Yeah, that's a great question. And you know what? I have to ask real quick, what experience or exposure would a pathologist have to ketamine? I can't think of any myself, but have you seen it in your practice? Probably not, I'm guessing.
The only real experience I've had was at autopsy.
That was what I was thinking too. Yeah. And rare, I hope, because as I will come to help you understand, or our audience understand, ketamine is a safe medication. It is not implicated in overdose commonly, if at all. But yes, we'll talk about it. Very cool. I didn't know you were an almost anesthesiologist. It's too bad. I was an almost pathologist. Maybe we can talk about that again another day.
Cool.
All right. Well, so ketamine. Ketamine's a fascinating substance. It's a dissociative anesthetic that provides potent acute pain relief at subanesthetic doses, long-acting neuropathic pain relief at subanesthetic and higher doses when administered over a period of time, number of hours to days. And of course, it induces anesthesia when given as a large bolus all at once. Now, it took some time to discover these various effects, but really ketamine started its life out as a different drug called phencyclidine, also known as PCP. So PCP, or phencyclidine, was synthesized and initially used as an anesthetic agent, and it safely gets people unconscious, makes them unconscious for anesthesia, so that surgery can be performed without the patient waking or moving, or so forth. The problem with phencyclidine as an anesthetic agent is that it has a protracted emergence problem. Patients spend a lot of time confused in the PACU and agitated and even violent, so it was not ever taken up as a regularly used anesthetic. The search quickly was on in the 60s to find something that would be as good as PCP for anesthesia without the emergence delirium, and so ketamine was born. Ketamine does have psychometic side effects that we can induce easily at subanesthetic doses, and that may be seen on emergence depending on how the anesthetic is given during the course of the operation. But what I mean is, at certain doses, ketamine can cause hallucinations, it can cause delirium, it can cause agitation. So these unpleasant side effects made it less ideal as a general anesthetic than what we commonly use today to induce, such as propofol. So it kind of got relegated to the back shelf, and it sat there for a long time. But in the beginning, one of the main reasons this class of medication was so desirable is that it could induce anesthesia while also maintaining hemodynamic stability. So what I mean is somebody can become unconscious on this, suitable for anesthesia, without dropping their blood pressure to an unsafe zone or changing it significantly. And without stopping their breathing. So those are two critical things that happen very often with other induction agents, and as anesthesiologists we're trained to manage those. But ketamine and PCP don't do that. So ketamine always stayed as an agent in our emergency trays because we need to be able to sometimes induce somebody very quickly without having to worry about hemodynamic stability or breathing. Let's say, for example, in the setting of an emergency, somebody's bleeding out. We have that to worry about. We just need to make them unconscious. So we'll find ketamine use in the emergency room. We'll see it in the operating room for emergency inductions. You'll see it in ambulances and sort of emergency situations out in the community. You'll see it in the military setting for trauma control or trauma relief during an acute period. And there's also another use for it in the pediatric population, unrelated to its hemodynamic properties or directly. But it turns out when given at a sort of a subanesthetic dose, ketamine is a very good sedative for children. Children tolerate it well, don't have any problems. And so we'll often give ketamine to children perioperatively just to start an IV. They get a little pinch in their shoulder when they're not looking. They don't love that. But very quickly they become sedated and are suitable to start an IV, and then we can begin. And then finally, ketamine is very commonly used as a veterinary anesthetic for both small and large animals, thus earning the nickname that you may have heard, horse tranquilizer. But yes, it is true. That is another use for ketamine.
Okay. Now, you said something interesting.
Yeah.
You said you started giving it to kids.
Yeah.
To kind of help them to be okay with shots, and my first thought was my wife is a child life specialist, and so that's like what she did in at McKD. She would sit there with the kids, and she would help to prep them for this induction of anesthesia. She would help to prepare them for coming out of anesthesia, what was going to happen when they come out, and if they even remembered it. But and so she has a lot of experience with that, and so I'm thinking ketamine is kind of the emergent child life specialist as well.
It's an amazing and very versatile drug. Yes. Yeah. You won't meet a pediatric OR. You won't meet somebody who works in pediatrics like your wife, or say the dentist's office when they need to do tooth extractions with anesthesia. You won't meet somebody who doesn't love ketamine because of its ease of use and safety profile. So that's how ketamine lives, and we really don't hear about it day to day, except for if you've been paying attention in the last 2 to 4 years. where ketamine has just had this explosion of popularity. And I feel like the more I talk to people just casually, the more people are saying, oh yeah, I heard about that thing called ketamine. Can you tell me more about it? So this popularity, we can go into that a little bit more. Why is it something that we're talking about right now? And this is something that's taken many, many years to develop momentum, but we'll kind of go back to, say, the 70s or so. It wasn't very long after ketamine was introduced that as an anesthetic, that it was realized that it had potent analgesic or pain relief properties too. And we could see that after somebody had anesthesia with ketamine, they woke up with less pain. But then we also realized that we could give a sub-anesthetic dose, or maybe a tenth of the induction dose, in the recovery area, and patients will feel better. And in fact, they'll feel just as good as if they got, say, a shot of 10 milligrams of morphine. And that profound pain relief that we could give with ketamine instead of with morphine meant that in certain situations when somebody was prone to respiratory depression in recovery, say they have sleep apnea, they had a lung surgery, they already had a lot of opioids, any number of reasons, we could spare them additional risk of respiratory depression by giving a little bit of ketamine. So its profound analgesic relief effects were known very early on. By the 80s, physicians were studying prolonged infusions of ketamine in certain pain patients or certain patient populations while in the hospital to see how that affected severe pain in the long term. And so some of our earliest studies for people with severe pain that were being treated with ketamine for that severe pain come from hospital studies and in particular ICU-based studies where patients would receive continuous infusions of ketamine hours on end, days on end. And if you could imagine extrapolating some of those early studies, you would think, well, this is just not something that could be replicated outside of the ICU. There's no way somebody can get a continuous infusion for 1, 2, 3, 4 days. And people were getting 100-hour infusions. So it took a long time for this initial use to kind of translate into an outpatient setting. But again, as time goes on, people were trying out different ways to replicate this kind of long-term continuous infusion that was seemed to be successful in the ICU chronic pain setting. And some following studies would, for example, give a continuous infusion of ketamine over 2 to 4 hours. And they would repeat that for a couple of days. And so eventually we were able to get out of the ICU into a clinic-based setting to start seeing how we could practically use ketamine on the outside world. And then in the 2000s, ketamine was actually being used as a model to mimic schizophrenia because at the right dose, you can induce those psychiatric side effects of dissociation, depersonalization. And so ketamine was being used to kind of develop a model of schizophrenia, to study schizophrenia. And it was quickly realized in these healthy volunteers that the doctors were trying to induce temporary schizophrenia, and that these patients were actually getting profound relief of severe depression. They had comorbid depression in some cases, and they'd say, well, I feel fine, I'm thinking clearly, I don't have schizophrenia. They would be tested, not report that, but they would find that the patient was completely normal the next day. But then they would say, hey, by the way, I was really depressed and I'm thinking about killing myself, and that's all gone. I feel better now. So this was a profound serendipitous realization that occurred. And so now really the most exciting area of study, the most active area of study is in the field of psychiatry, where ketamine is being used to almost immediately relieve severe, intense depression and active thoughts of suicide on a temporary basis. So anyway, that's the story of how we got to where we are today.
Wow, I didn't know that. Thank you for sharing.
Yeah.
That's super cool.
Yeah.
And then you said so many things that caught my ear. I took some notes, and then basically the message that I'm giving, if I can kind of recap that, is that ketamine was found to have while it was intended for it had secondary effects, and these secondary effects were quite beneficial. And it's the biggest one, and I think the one that hit me the most, or that I understood the most, was the effect on depression.
Yeah.
And I liked the fact that it's stable for patients with cardiovascular disease. It helps to for hemodynamic stability. I liked the part that talked about the 1/10 of a dose. The ketamine seemed to have profound effects on how you think in your
Yeah, that's a really good question. And that's something I always struggle with in my brain. There's very much a dose-dependent relationship there. So the respiratory center, I believe the doses that you need to get to depress the respiratory center are far in excess of what's given for anesthesia. So the anesthetic dose of ketamine is somewhere in the range of 1 to 5 milligrams per kilogram, usually 1 to 2 milligrams per kilogram body weight. In a single bolus, and the respiratory depression effect might occur somewhere between 50 and 200 milligrams per kilogram. So it's a dose that nobody would use in a medical way. But there are other places that it will work, and so there is some direct opioid analgesic effect from ketamine. So I'm bringing this up because we got to kind of take pain apart and think about it and think about how it works. And yes, my focus will be predominantly on pain. We'll get to depression too, but let's just start with some basics. Pain is classified by the International Association for the Study of Pain, the IASP, as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So it is a response that we have to being hurt or possibly being hurt, and it is an emotional response. So you cannot separate your brain's processing of pain from the signal of pain, because pain can only be something that you sense and have when you're conscious. If you are unconscious, you cannot have pain. You can have your skin cut, and that can be very stimulating, and your sensory ends can be torn apart or crushed or burned. But if you're not conscious to process that information, you're not going to feel pain. So what is happening when there is an injury at the tissue site is called nociception. Nociception is the result of the activation of peripheral nociceptors or nerve endings. These are either chemical, mechanical, pressure or stretch or temperature by actual or potential tissue damaging stimuli. So what I mean by that is you can actually have harm, like a chemical burn if you burn yourself with lemon juice, for example, or some you can have a potential tissue damaging stimulus, like you touch a very hot stove, but maybe it doesn't injure you. Both of those things will activate your nociceptive pain receptors, and those afferent receptors will take information from the periphery into your spinal cord. And then we think of those as either somatic or visceral. You have your skin, for example, or an end organ that can be injured, like an appendicitis, and both of those can transfer pain ultimately to your brain. So that's nociceptive pain. Neuropathic pain is a result of direct injury to the tissue or a disease of the somatosensory system or the nerves. It begins with an injury to the nerve structure, either in the periphery, so like a neuropathy. You may be familiar with diabetic peripheral neuropathy. CRPS2, we won't get into that right now, but that is a direct nerve injury. Or it can be from an injury to the central nervous system, such as a spinal cord lesion or a stroke. So that is neuropathic pain. That is an injury to a nerve directly. What happens is when we have an injury, the spontaneous pain that comes with it, you know what, actually, I'm going to come back to that. There's a third type of kind of pain that we're going to kind of touch over briefly, but it's referred to as nociplastic pain. And this is sort of a new construct, but it is a type of pain where there's no clear evidence of tissue damage or disease to the somatosensory system, but nevertheless, there is intense and severe pain that is measurable and detectable. And this is what we see in fibromyalgia, irritable bowel syndrome, CRPS, and nociplastic pain is definitely a combination of what we talked about, neuropathic and nociceptive pain. So it's this kind of mixed pain state. Another thing to think about when it comes to pain is it acute or is it chronic? We classify pain in these two distinct categories because they really are different in important ways. Acute pain is a protective mechanism. It's a stimulus that reflects real or potential harm or threat that must be responded to for the sake of life or limb. It's typically self-limiting, and it is protective. It's associated with muscle spasm, sympathetic activation, or like increased heart rate. That's acute pain. Goes away, and it's important to respond to it. Chronic pain is pathological pain. It is the perception of pain that is present despite tissue healing and the harm no longer being present. And it may also stem from psychological states. So it may be exacerbated or present because of the emotional response or the interpretation that we have of the original injury. There's no obvious biological benefit to chronic pain, and it does not have a recognizable or expected endpoint. So chronification of pain is an important part of the onset or development of chronic pain when acute pain becomes chronic. Chronification is when there's prolonged nociceptive stimulation. So you have that end tissue nociceptor that is being constantly triggered. One of my favorite simple examples is arthritis. You have arthritis in your knee, and that's where the pathology is, and that's where the nociceptors are being stimulated. But that signal continues unabated. And what happens is your body becomes very efficient at taking that information from your knee to your brain. Your body wants to get to homeostasis. It wants to get to efficiency. So it takes that signal and it says, hey, you know what? Why don't we just, why are we making this so hard? Let's throw a couple more nerve ending or more nerves along the pathway. And so you get this upregulation in the central nervous system, in particular, upregulation of the NMDA receptors in the dorsal horn of the spinal cord. And that in turn enhances or amplifies the pain signal to the brain. And thus
you're essentially creating a highway where a city road used to be.
Exactly. Yes. And that's my favorite analogy to give. I say, a 2-lane back highway that's become an 8-lane each direction superhighway, with all the congestion that comes with that. So yes, chronic pain is beyond helpful. It's pathological, and we have all of this extra work being done, in particular by the NMDA receptor, to facilitate that pain. So
how you explain that is it's just incredible. I was able to follow you through the whole way. It's really, really cool to be able to understand. Now we have pain, but it's not just pain per se. It is the perception of actual or perceived stimuli, and that is huge, because it gives us, I think, more power over pain, whether we want to know it or not. That sometimes when I feel pain in my knee, I'm like, when I'm running, it's like, is this just like pain that's going to stop me from running in a half a mile, or is this like pain that I can just run through?
Yeah. And that's a really great example that you give, because a lot of times, I always tell my patients, knowledge is power. Once you get to know your body, and your pain, the more you know your pain and understand your pain, the more powerful you are, and the better you can treat yourself. But I'm thinking of a story that I heard somebody share about a patient who was an avid athlete and played and lived for playing their game. Also a very powerful business person, but developed a pain in their foot and could no longer play their game. And that's what they lived for. And so life was very devastating. This person had to walk around on crutches and just couldn't walk. Upon examination, the person was found to have a neuroma in the foot, a Morton's neuroma. That is a painful bundle of nerve endings that abnormally grow, but they're not going to cause harm. And so as soon as this patient learned that walking on the neuroma, though painful, is no longer harmful, they ditched the crutches and walked out of the clinic. They were fine because that pain was something that hurt but didn't harm. And because there was no actual harm, they were comfortable walking on that foot. And that goes back to kind of the emotional processing that we have and the control and power we have over our own pain. If you think that you're going to be injured or harmed, then yes, we can be debilitated and stopped. But if you know different, that maybe what I'm feeling right now is something that hurts, but I know it's not going to break my foot and I'll still be able to walk, then that's a very different thing. And anyway, so I love helping people learn what pain is in their body. And to that end, kind of circling back to chronification and what I see in abnormal pain states, to the extent that I can help with that chronification using ketamine, then I can help people hurt less and suffer less. And then also people kind of learn what their pace is and what their limits are and actually meet them instead of kind of staying on the couch all the time. So, yeah, thanks for that example about running. So it's really interesting where ketamine can help in the body. Some of its end organs, we've talked about the spinal cord, but I'll just kind of take this from the periphery and work our way in. But first we have the nociceptive afferents. Those are the somatosensory end organs, your skin, your joint, your viscera, peritoneum, that part of the body that's touched and gets hurt. Ketamine blocks the NMDA receptors on the presynaptic afferents here and essentially enhances the release of excitatory substances, including glutamate and substance P, which basically give you pain relief. Okay, so that's step one. Step two, in the dorsal horn, where these nerve endings are connecting and then sending a signal up to the brain, the dorsal horn of the spinal cord, ketamine acts on the NMDA receptors in the dorsal horn. And then when we get to the brain, there are many pathways here: the anterior cingulate cortex, the orbital frontal cortex, the insula, the brainstem, and one thing that I've mentioned a couple times, the descending pain inhibition pathways. And all of these are activated, but in particular, this descending inhibition pathway is something that basically feeds back to the body, hey, stop telling me I hurt, I already know. So NMDA works there, ketamine works there to kind of turn off that pain signal. But those brain pathways that I just mentioned, there's a lot of overlap. There's no one place that the pain is processed in the brain. And this kind of diffuse distribution of receptors just kind of goes to show how pain can be so complex, but also how these same mechanisms can help with things like depression and memory care. But anyway,
it makes me.
Oh, sorry. Go ahead.
Sorry. It kind of makes me think, evolutionarily, like pain is obviously a very important thing for our bodies physiologically.
Mm-hmm.
We need to make sure that we're taking care of ourselves and we're not causing ourselves harm. And so we have multiple different, places and locations where pain can be sensed and interpreted by our brain, because that's a very important thing. If you're burning your hand, you need to know that you stop burning your hand. But then it also means, like, if we want to turn that off, then it becomes a little bit more challenging as well. And then I'm wondering, and this goes back to I wish we had a psychologist. There you are, a psychiatrist in here.
Yes.
We have them give their 2 cents, because I really wondering just how that interpretation of those stimuli really does affect, like, how much does that affect your sensation of pain? Because I know there's sometimes when, I'll get like a real bad cut and I'm like working or I'm like running or I'm doing something and then I won't notice it until I'm done.
Yeah.
And yet there are other times when I'm like, shaving my face and like I like nick the side of my cheek and it's like, oh, like it barely made a little scratch, but like that hurts like crazy. And I don't know, so how much of an effect does that have, and when does that have an effect?
Well,
that's my question.
No, that's a great lead into something that I was thinking I wanted to bring up, and that's the affective motivational component of pain. So I mentioned the end organ, the sensory discriminative part. So you have the injury on your extremity, and that's the hurt. And then you have, what I also think, we talked about hurt and harm. I also like to think of pain and suffering. So you have the pain or the cut or the injury on the extremity, that's sensory discriminative, but then you also have how you're processing it in your brain, and that's the affective motivational circuit of your brain. That is the suffering. And to the extent that you're able, and people can learn this through mindfulness and training, you can modulate your affective motivational pain component. You can say, I am bleeding, I am cut, and I can see that it's causing pain. I will not let it cause me to suffer, or I'm not suffering from this. And then on that opposite end, let's just take a young child who doesn't really know any different, but they see blood. It's the worst thing in the world, and they're going to be screaming because they're suffering. They don't know if that blood means that they're not going to have a finger or something terrible. So yes, so ketamine works to increase those dendritic connections that we're talking about. It also decreases microglial inflammation, and all of this affects pain processing in the affective motivational components, which overlap with those depression circuits and maybe the PTSD circuits too. The PTSD effects are still being worked out. But that's why there's this big tangle between chronic pain and depression, and then also these two separate entities that are chronic pain and depression. Some people are depressed because they have chronic pain. Some people have chronic pain, which causes, some people have depression, which causes pain, and everything in between those two spectrums. But yes, so pain and suffering are two different things that have to do with how we interpret our pain, our stimulus in our brain. Okay, so let's get into the nuts and bolts of ketamine as a mechanism to these different processes that we've talked about. So the let's go back to the beginning. I talked about how ketamine can be very effective as an acute analgesic. So when it's given at subanesthetic doses, and I'm just going to use some round numbers. These numbers are very much dependent on body weight and way that the medicine is dosed. Is it infused quickly? Is it given as a single bolus or spread out over an hour? But in an acute setting, we would say give a tenth of an anesthetic dose. So let's say an anesthetic dose is 200 milligrams. An acute analgesic dose would be a single bolus, quick injection of, say, 20 milligrams of ketamine. That acts directly on the nociceptive afferents in the dorsal horn to enhance the release of glutamate and substance P, and that is pain relief. And it also works on those descending inhibitory pathways to give pain relief. So that is acute pain relief that you can give somebody, usually in a hospital setting or a controlled setting. In my chronic pain clinic, when I have patients come in with acute pain that need kind of immediate relief and don't want to go to the ER or can't go to the urgent care center, I'll give them acute doses of ketamine under observation for 2 hours and give them the pain relief. Then we have chronic pain management with ketamine, and that's where a lot of my work is done. And the chronic pain pathways act to counteract mechanisms of pain centralization via resetting the pathway. So what do I mean by this? So, earlier we talked about that country road turning into a superhighway. So all of that, and that's all done through upregulation of NMDA receptors. So when we give the ketamine to antagonize this, we can, and we do this over a prolonged period of time, we can downregulate those receptors and downregulate those pathways. And so when we do this as an infusion, and I told you earlier too that these really early chronic pain studies were done like in the ICU for dozens and dozens of hours. We're talking 100 hours. So that's not practical, but what was seen is when this continuous, maybe it's a sub-anesthetic dose, so somebody's not unconscious, but this continuous background dose was given for so long, their chronic pain would go into remission of sorts. And that's because those receptors, those pathways are being downregulated, going from that express 8-lane highway to, country road. So how do we copy that or make that practical for outpatient use? And the way that we'll do that in the chronic pain setting is we want to give a dose that's effective or able to do that over a short period but reasonable amount of time over several days. So my patients, first what we'll do is we'll bring them in and we'll induce them, if you will, or we'll get them used to ketamine. So they start with kind of a small basic dose. I infuse it slowly over 4 hours so that the blood concentration is relatively low, probably too low to start this reversal of chronification. And then we come back the next day and we do the same thing but a little bit higher. And we repeat this for about 8 clinic days. And by the end, we've gotten to a high enough dose that's infused over about 4 hours to give the patient a constant blood level that hopefully reverses chronification. And that's what we wind up seeing just about all the time when the pain is the right pain. In other words, this will work for neuropathic pain and chronic pain. This won't work for your peripheral nociceptive pain. Somebody comes in with a broken arm and I do chronic pain infusions on them, their broken arm is still going to hurt in the same way as it did before the infusion started. Does that make sense?
Yeah, it's a physical nociception of an actual pain.
Somatic pain.
The perceived pain.
It's not the central pain. Yeah. So perfect. So I guess I need to take a step back and talk about patient selection. It's really important that we have proper patient selection. This is true for, anytime you pick a medication for somebody, you're not going to give aspirin to everyone because not everyone needs it. And then if you do, they're going to have complications undoubtedly because you've given it to everyone. So picking the right patient is critical. And so when it comes to ketamine for chronic pain, we're looking for neuropathic pain. So pain that is because of an injury to the nerves or this chronification process that we talked about. So
chronification and injury to the nerves.
Yes.
They're both treated similarly. Like we can, those are the patients that are ripe for ketamine treatment.
Yes. Yeah. Okay. So again, let's take somebody walking in off the street. You have an arthritic knee that's been bothering you. Very good chance that ketamine infusions won't do very much for you. Walking in off the street, you have diabetic peripheral neuropathy. Very good chance that we can do something for you. And then where ketamine and pain has been studied the best the most is in CRPS type 1. Are you familiar with CRPS? That stands for... That's okay. Most people...
I've heard it before. I just don't remember what it stands for.
So old-fashioned names...
Syndrome.
A complex regional pain syndrome. And
okay, close.
That's right. And old-fashioned names for it are causalgia, and regional sympathetic dystrophy. So complex regional pain syndrome manifests as an upregulation of the autonomic nervous system to a region of the body. And it's due to a direct insult or injury to a nerve. CRPS is split into type 1 and type 2. The old names were causalgia and RSD, but we simplify it with type 1 and type 2. Type 1 is when you have this phenomenon of CRPS but no obvious tissue nerve injury. Type 2 is when you have the phenomenon of CRPS, but there's an obvious nerve injury, like somebody had their sciatic nerve cut. So what it is a this autonomic upregulation in a region, so like a hand, a foot, a knee, whereby the autonomic output fibers are kind of in overdrive to that extremity. So somebody comes in, they have a foot that's purple, it's edematous, it's incredibly sensitive to the touch, it's really hot. So a lot of those findings are autonomic. The swelling is an autonomic function. The purple color, that's vasodilation, that's an autonomic function. The edema, same thing there. The temperature increase. And what happens is an injury happens somewhere. We don't know where, because this particular example I'm giving you is type 1 CRPS. So something happened to injure the nerve pathway. And then there's an injury, and then the upstream in the spinal area, the autonomic nerves, which sit in front of the spinal column, are hyperactive and sending out too many signals, which is why you have this dysregulation of sweating and edema and blood flow. And with those signals also come pain signals, and patients feel exquisite neuropathic pain or exquisite pain in that limb. So it's an unusual phenomenon that we don't really have a clear understanding of, and why it happens and who's at risk. But anyway, when people hurt from CRPS, they're suffering very badly. And so CRPS type 1 has been a classic case that has been studied with ketamine, and people who get ketamine for CRPS type 1 tend to go into remission of their pain symptoms for a prolonged period of time every time they get their infusions. Ketamine works on both acute and chronic pain. It works on acute pain via those nociceptive afferents, and chronic pain working on the chronification pathways. Ketamine also works on depression at sub-anesthetic doses and can give an immediate improvement in antidepressant side effects, in suicidality and severe depression within an hour of dosing. But the difference between treating for pain and treating for depression is in the dose. Depression routinely responds to a pretty narrow range of dosing. I want to say between 0.1 and 0.5 milligrams per kilogram infused over 40 minutes. Whereas when it comes to chronic pain, we will strive to give the highest tolerated dose to reverse the centralization or chronification, or unwind the wind-up that happens with chronic pain. And so for that reason, ketamine will be dosed very differently when you're taking it for depression versus when you're taking it for pain relief.
So I had one question real quick.
Yes.
I found a study, really interesting, that talked about the NMDA receptors, and they are they help one, and it's they connected appetite and food preference to the NMDA receptors. And they said that it's important to distinguish between whether you eat food out of a hedonic desire or out of a homeostatic desire. Is associated with, and so that, to me, I'm like, well, that also relates to depression. Am I happy about something because I'm hedonic about it, I'm pleased about it, or am I happy because it's a homeostatic desire? And that kind of, that, I don't know what to make of it, because I'm not a psychiatrist or anything, but that does seem very likely to interrelate with depression as well.
Yeah. Well, that's interesting. And as you, I'm sure, well aware, depression is often associated with an abnormality or change in diet and appetite. So some people will overeat, or they'll stop eating. They'll have loss of appetite. And it sounds like that's a direct connection there. I'm not familiar with how, say, ketamine alters the appetite. In my experience, I'll say I'm not aware of people like going home and eating more after they've had ketamine, for example. But all the time, and again, to just reemphasize, the way I dose is higher and longer than the way my colleagues in psychiatry dose, so very different. But all the time, I have patients who have comorbid depression come to me and say, this ketamine has changed my life. We didn't set out to give a psychiatric dose, and we are exceeding the psychiatric dose, so it's not too much a surprise that we're capturing that. But not only are people feeling better, but they are feeling better in spirit too, which, yeah.
So that's exactly what we want.
That's exactly what we want. And we're getting people up and moving. And as you probably are well aware, it's not enough to just, take a pill to treat something like, take an antihypertensive. You really need to you need to take that medicine, but you also need to change your lifestyle. You need to eat better. You need to exercise and diet. So same too with my patients, I get them the ketamine and I help them feel better, but then they need to go and have a schedule. They need to wake up in the morning. They need to have regular meals, have a job or a volunteer or some kind of activity to look forward to. And all of these things are interrelated. And we know that the activity, the good health of being healthy is a very important part of the treatment that we do. So,
I agree.
So typical dosing for ketamine is at sub-anesthetic doses, which are by definition somewhere between 0.35 and 0.5 milligrams per kilogram as a bolus, followed by an infusion of less than 0.5 milligram per kilogram per hour. So that's less than the anesthetic dose of 1 to 2 or maybe 3 milligrams per kilogram, but usually 1 to 2 milligrams per kilogram given as a bolus is sufficient to induce anesthesia. So that sub-anesthetic dose of 0.35 to 0.5 is sufficient for both at the lower end depression reversal and at the higher end reversal of chronification. In chronic pain, we also tend to titrate the dose to the highest tolerated concentration in order to reverse the centralization effect. And so I presented the dosing ranges, but we may give 1.2 or more milligrams per kilogram per hour as an infusion in the chronic pain patients, simply because that higher blood concentration is more likely to induce this reversal of centralization. Ketamine's effect is profound but short-living, and so because it's short-living and because we want to have this prolonged blood exposure, usually chronic pain infusions last at least 2 to 4 hours. And again, I keep citing a previous study where infusions were given for 100 hours. But when this is done for such a prolonged period of time, in the model of CRPS type 1, at least, there was prolonged pain relief of more than 50 days recorded. And in my clinical experience, I typically see anywhere from 4 to 8 weeks of meaningful pain relief when we give anywhere from a 2 to 8 day infusion, depending on whether we're running in or maintaining the patient. So it is a very time-consuming process when you first start receiving ketamine. And then in follow-up, when you're receiving maintenance doses, it's still a 2 clinic day time commitment. But the result is that prolonged relief for 4 to 6 weeks or 4 to 8 weeks. The American Academy of Pain Medicine, the American Society of Anesthesiologists, and the American Society of Regional Anesthesia and Pain Medicine came out with a consensus guideline in 2018 on the use of intravenous ketamine infusions for chronic pain. Now, that consensus guideline is a very important document that summarizes the way that we would use ketamine for chronic pain patients. And I'll just briefly go over that, but you can find that on PubMed easily. But indications for chronic pain intravenous ketamine infusions include spinal cord injury with some weak evidence to support short-term improvement, CRPS that we discussed about with moderate evidence to support improvement up to 12 weeks, and then other pain conditions such as mixed neuropathic pain, fibromyalgia, cancer pain, ischemic pain, headache, spinal pain, and other neuropathic type pains. There is weak evidence or perhaps no evidence. Nevertheless, that's where a lot of the studies are looking. So indications to review: spinal cord injury, CRPS, and mixed neuropathic type pains, including fibromyalgia, ischemic pain, head pain. Dosing range starts typically with an initial dose at about 0.35 milligrams per kilogram, with an infusion from 0.5 to 2 milligrams per kilogram per hour. There have been doses of up to 7 milligrams per kilogram per hour seen in refractory cases, but that is only in the ICU setting. At that dose, you are likely maintaining anesthesia. So outpatient dosing is somewhere between 0.5 and 2 milligrams per kilogram per hour. There is evidence for a dose-response relationship, with higher doses providing more benefit. And if the dose is going to be more than 80 milligrams total, it should be infused over a period of at least 2 hours to minimize side effects. Relative contraindications to ketamine include poorly controlled cardiovascular disease, pregnancy, and active psychosis. Of course, in all cases, such as cardiovascular disease and psychosis, ketamine might be administered in a very case-by-case consideration. Severe hepatic disease is another contraindication, as is moderate hepatic disease, a relative contraindication. Elevated intracranial pressure and intraocular pressures are relative contraindications, although rarely, if at all, is increased brain pressure or eye pressure seen with ketamine. And finally, active substance abuse. And again, back to relative contraindications. On one hand, you don't want to induce relapse of somebody who actively abuses a substance, particularly if that substance happens to be ketamine. But there is also evidence to suggest that ketamine may be helpful sparing opioid use, such as in the postoperative area. And so that might be a place that one would use ketamine for pain control, despite somebody having a history of substance abuse or active substance abuse. The role of NMDA receptor antagonism through oral administration has been explored and is somewhat actively used in very specific circumstances. So this is a circumstance where a prescriber may write a compounded prescription for ketamine to be administered orally via compounded trochar. This has very uncertain support with the literature. There are very few studies that have been completed on this, and the role for outpatient use is really uncertain. This is a controlled substance that is being put out into the community, and when we shift from a controlled substance that is used in a controlled setting, such as an office, to outpatient use outside of direct supervision, there are risks of overdose and other problems. So that is something that is still being actively studied. Pre-infusion testing is not necessary. There's no reason for a healthy individual to have blood work or EKG. If somebody has suspected or is at high risk of cardiovascular disease, a baseline EKG can be used to rule out ischemic disease. And individuals with poor liver function, such as alcohol abuse cases, or a patient with chronic hepatitis, should have baseline liver labs drawn, as well as post-infusion liver function tests. The efficacy of ketamine can be relatively easily measured in the pain population, as a positive response can be reported by the patient directly. Typically, a response of greater than 30% improvement from baseline is typically considered a positive response. Also, an improvement in the Oswestry Disability Index score of greater than 13% is also considered meaningful. As far as monitoring the infusion, a supervising clinician should be experienced with ketamine, and those people would include anesthesiologists certified in their specialty, critical care physicians, and pain physicians who have specifically been trained in that subject matter. They should also have ACLS certification and be trained in administering moderate sedation. The administering clinician should be somebody who has completed formal training in the safe administration of moderate sedation, and the setting should be a monitored setting that contains resuscitative equipment and immediate access to rescue medications, and personnel who can manage those emergencies.
So good. Well, Dr. Baca, thank you for being on this podcast today. We are really, really just amazingly blessed to have your knowledge and being able to have that infused upon us. And so hopefully we can all refer lots of good patients and well, not good, lots of good patients, but like lots of appropriate patients to you. And because I think it could really benefit society and really benefit our patients. So
yeah, I'm excited, and I'm excited by the things that we get to do in my clinic and that where the science is taking us. So thank you for that. Thanks, Dr. Moore, for having me on the podcast today. It's been a real pleasure talking with you. And if anyone has any questions, they can always reach out to me at my office website. You can reach me at nurses@peakpaincare.com, and that will forward eventually to me. It's been a pleasure.
Thank you for listening to our podcast. The producers for this podcast are Clark Madsen, Teresa Pusquedra, and the board of the Ogden Surgical Medical Society. Our executive director is Teresa Pusquedra. Our hosts are Heather Hellison, MD, and Scott Moore, DO. Editing and sound design by Eli Whittier, and supported by the members of the Ogden Surgical Medical Society. Thanks again for listening, and we'll see you next time.